Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Kara Wada. She's an adult and pediatric allergy, immunology, and lifestyle medicine physician. Today's Kevin MD article is titled Ragweed Allergy Peaks During the College Football Season. Kara, welcome back to the show.
Thanks so much for having me today, Kevin. How are you?
Good. I'm doing well. And we're here to talk about ragweed allergies. Kara's been on multiple times. Go to kevinmd.com/podcast. Upper right-hand corner, there's a search icon. You can click on that, search for her name, and hear her story. But let's jump right into your article, Ragweed Allergy Peaks During the College Football Season. Why did you decide to write it?
Well, I felt very inspired. I practiced clinically at The Ohio State in Columbus, Ohio. And having been here now for about 14 years, you have to sip the Kool-Aid at least a little bit when it comes to the excitement of the lifers and those who are very, excited about the Buckeyes and college football. And I thought it was really interesting that increasingly I had realized I was talking with patients about how they needed to start their allergy medications around the time the football team was starting up their practice if they had fall allergy symptoms. And I thought it would be a fun article to write.
All right. So let's get everyone on the same page. Tell us what
Yeah.
ragweed is and how common an allergen it is.
So ragweed is one of the key species that affect us in fall for fall time allergies or hay fever. Ragweed is a pretty nondescript plant. A lot of people will get it confused with goldenrod, which has that really pretty gold color, but usually ragweed is its cousin that's right next to it that's not super attractive. And it is incredibly prevalent. It is found in nearly all of the 50 states. It is even found in Hawaii. I think Alaska is the only state that it has not been found. And it tends to thrive in both urban and rural areas. And kind of surprising to me as I did my training as an allergist, I figured I grew up in a more rural area. I knew growing up surrounded by farms that we had a lot of pollen, a lot of dust, but it turns out ragweed specifically has much higher counts in urban areas because of these urban heat islands. They're areas that are warmer. Heat is retained in our concrete, our buildings. These ragweed plants are very, very hardy. They will take root in abandoned parking lots, along roadways, areas that don't get mowed. And one plant can produce over 1 billion pollen granules. And those granules can stay airborne for up to 400 miles. So they are prevalent and persistent.
So patients who have allergies to ragweed, how do you encounter them in the clinic, or how do they present to a primary care physician like myself?
Yeah, so typically around the middle of August, in most parts of the US, we will start to see the onset of fall allergy season. In part, ragweed and many of its fall allergen counterparts, their pollination is cued by the length of daylight rather than temperature. When we think about spring pollen season, we're waiting for the snow to melt, and that will kind of signal to the plants that it's time to reproduce. Ragweed and weeds are more reliant on the length of daylight. So that start time is pretty consistent. And people will notice, around that time that school is getting back in session, that they may be having itchy, watery eyes, runny noses, itchy nose, sneezing, increase in their asthma symptoms. So cough, chest tightness, or wheezing. And all of that is suspicious for fall allergy or ragweed allergy.
Now, is there a particular demographic that may be more susceptible to ragweed allergies?
Everyone. So typically we would say for, on the younger end of the spectrum, people tend to need to have been exposed to the pollen at least for one season. So we would say it'd be incredibly rare to see a child have seasonal allergies before they're about 2 years old. They need to kind of live through a season and then come back to that season again. But we can continue to see seasonal allergies throughout the lifespan. Most often, we would say, as you're getting towards retirement age, the immune system tends to be less likely to make new allergies, but I still will meet, on occasion patients who are well into their golden years that are
Mhm.
still having significant issues.
Now, over the past few years, have you been noticing that the fall ragweed season has been progressively getting worse?
Yeah. So when we think about what ragweed needs to thrive, and really most plants need to thrive, they need some sunshine, they need water, they need carbon dioxide, and the warmth. And so when we think about, for instance, where I live, Columbus is a relatively young city. We've had tremendous growth in our
Mhm.
metropolitan area over, even before I got here, but in the 14 years I've been here, we have continued to see an upward trend. And in this year in particular, we had on September 5th, ragweed counts that were nearly twice as high as they hit at any point during the season last year.
Now, does climate change have anything to do with the worsening ragweed counts?
It does in a couple ways. One, we have more of the fuel to, promote ragweed growth. But we also see a lengthening of the pollen season. And the further you get away from the equator, that change is increased. So for our listeners who maybe are in Canada, they may see then a longer pollen season or a greater increase than those of us in Columbus compared to maybe those down in Texas.
So, I want to talk about a couple of different case scenarios. Number one, someone who presents to me or you with acute symptoms that may suggest a ragweed allergy. And a second case, someone who has a previously diagnosed ragweed allergy and wants to inquire about more preventive options. So let's talk about that first scenario first. So someone comes to you or me with acute symptoms that may be suggestive of a ragweed allergy. What's your approach?
Yeah. So in that situation, we're trying to put out the fire. We're trying to help that patient get back some quality of life, be able to think better, breathe better. So, one of the things I'm going to key in on are what symptoms are really driving most of their suffering. If it's itchy, watery eyes, eye swelling, then using eye drops may be really beneficial, really helpful. If it's nasal congestion, then sometimes, most often I'm going to be recommending doing a combination of things like maybe some saltwater rinses if there's a lot of mucus production, using a nasal corticosteroid if there's significant stuffiness or tissue swelling, and then thinking about one of the medications that's newer to the over the counter options that we have out there, which is intranasal azelastine, which is an
Mhm.
intranasal antihistamine. And that does tend to work quite rapidly and quite well at drying up drainage and helping with that itching as well.
So, when making that choice between an intranasal corticosteroid like a Flonase or Nasacort and the intranasal Astelin, do you have a preference between one? What kind of advice can we share with these patients when they're confronted with a million nasal medications in the
Yeah, there
drugstore?
is. You go to the allergy aisle and you're inundated. So I would say if you're having most trouble with stuffiness, getting air in and air out of your nose, you have to have an intranasal corticosteroid probably on board. That's going to work the best at shrinking down those tissues. That being said, people will notice some differences between brands. Some people may tolerate different brands better. So if you've tried one, haven't found it terribly helpful, it may be worth trying another. The other, little sticking point with intranasal corticosteroids is they take 2 to 4 weeks to get to their full effect. And you really need to use them like you would a blood pressure medicine. So on a regular basis, even if you don't feel like they're doing much. The improvement is gradual. And that's where I think sometimes using a combination, adding in the azelastine along with it can be helpful because the azelastine is a little quicker in its onset of action. May not help shrink the tissues down as quickly or as well, but you may get a little bit more of that effect that you need to get you to stick with it. And so often by the time people reach my office, we're talking about maybe using a combination of both. So we're kind of hitting things hard to get that inflammation turned down.
Patients sometimes ask me about Afrin, that's also available
Yeah.
around that area. Contrast Afrin with the
Yeah.
corticosteroid and the azelastine.
So Afrin feels like a magic wand sometimes when you use it. It is quite immediate in its onset. It is a nasal decongestant. It tends to work very well, but like everything in life, there are some consequences sometimes when when we take the easy road out. And so Afrin can at times be incredibly helpful, especially if you are totally congested, obstructed. But if used for a prolonged period of time, we say more than 3 or even 5 days in a row, we can see those tissues in the nose become accustomed to it. The receptors change. And essentially, your nose tissue can become almost addicted to needing it to stay open. So I always tell patients, if you find yourself in a pickle, you've been overusing Afrin, don't feel ashamed. Come see me. We'll get you off of it. We'll get you feeling better. And I don't blame you because, wanting to feel open and clear is, you know, it, it feels much better than being stuffy and everything. But at the same rate, it is not a good long-term solution. Our worry over time is that it can cause damage to the tissues and the vasculature in the nose, can cause issues with the septum. And so helpful in a pinch, short use, but you need to think about those other nasal sprays, which are much more effective and safer for the long term.
Now, what role do oral antihistamines play, like a Claritin, Zyrtec, or Allegra in this scenario?
They're a fantastic first line agent, but I will say they have their limitations. They're not the best at keeping that tissue swelling under control or that congestion. So if you are really stuffed up, it likely may not be sufficient. And when we've looked at head to head trials between those long acting antihistamines with the medications like Flonase, the intranasal corticosteroids, the nasal sprays win when we compare the two.
Early on, you mentioned eye drops for those with eye symptoms. So go into
Yeah.
more detail in terms of what patients should be looking for at the drugstore.
Yeah, so you do want to, you're going to run into similar issues that we talked about with the nose spray. So there are quite a few products that have agents that will constrict the blood vessels, take the red out. So if it says something with red eyes, you probably don't want that particular product. You're going to want to look for, some of the ingredients I tell patients to look for are, again, that azelastine we talked about in a nose spray, comes in an eye drop too, under several different brands, and the generic olipatadine is another mainstay of eye drops. These eye drops occasionally will burn when you initially put them in. So keeping them in the refrigerator can help mitigate that, help have a little bit more of a cooling relief. And if you're someone who wears contacts, it's important if you're going to use eye drops, you need to put those eye drops in first, wait about 15 minutes, then put your contacts in, or wait till the end of the day when you take your contacts out to put the eye drops in,
And what's the reason for that?
just so that they're actually effective and not mucking up your contacts.
So let's talk about that second scenario, someone with already known ragweed allergy and wants to prevent these symptoms going into ragweed season. What's your approach there?
Yeah, so I applaud them. And when we think about inflammation, I think about horses in a barn. If you can keep inflammation from, getting out of control, it's a lot easier. You can usually use less medication over time. So one way we can do that is to start medications early. If you know that this season was particularly bad, maybe you set a calendar alert for August 1st of next year. Oh, I got to start my Flonase or Nasacort early. The other option you can consider is to meet with a board certified allergist immunologist. We have other tools in our tool belt, so immunotherapy, ways to desensitize your immune system so that it doesn't respond to that ragweed as the enemy. It starts to ignore it. Those treatments do have a little bit of a lag time though. So if we're starting shots, for instance, that may take, 6 months or so to get up to your target dose to see that effectiveness before the next pollen season. If I'm using something like sublingual or under the tongue treatments, which come in tablets and occasionally in a liquid form, we usually say that takes about 3 months to get up to its full effect. And then there are some newer options that increasingly are becoming available, something called intralymphatic immunotherapy, which essentially shrinks the treatment course down. When we think about traditional allergy shots, that was a 3 to 5 year long endeavor, similar with sublingual, and intralymphatic shrinks that down actually to just a couple months. So, I think it's helpful if you've explored these options in the past to know that there are some new things out there and that can provide relief, knowing that, especially with climate change, this is going to continue to be an issue over the long term.
So regarding that intralymphatic option, talk more about
Yeah.
that in detail. What exactly would that entail?
Yeah. So there are a small group of allergists that are providing this. So intralymphatic immunotherapy takes about 1/100th of the amount of allergen we would use in traditional allergy shots. We inject that allergen under ultrasound guidance into the inguinal lymph node. And what is really neat about using the lymph node specifically and directing it there, when you typically do an allergy shot in the back of the arm, we then are relying on our immune system cells or white blood cells to capture that allergen and bring it back to the lymph node. The lymph node is essentially the factory where that immune system change is occurring. So we're delivering that allergen directly to the factory. So you need less of it injected there. The other thing that's really amazing about lymph nodes is those cells that have the potential to create anaphylaxis, mast cells, are not present in lymph nodes. So when we talk with potential allergy shot patients, we're also assessing what is their risk. Are they on medications like beta blockers or other things that may make it harder to treat anaphylaxis? Are they at risk? What are kind of the safety concerns? Because we
Mhm.
say about 1 in 200 patients may have a more significant reaction to their allergy shot. So I think there's a lot of excitement around that aspect to care as well. And then in the studies that have been performed, it's a series of 3 injections in that lymph node at week 0, at week 4, and week 8. And we're seeing improvements that are comparable to those that we've seen in other types of immunotherapy under that accelerated course.
Now, give us an example or case studies of the type of patients that me as a primary care physician should consider
Mhm.
sending to you for some of these more involved treatments.
Yeah, so I think, perfect candidate is someone who has tried all the different medications or perhaps is not tolerating medications well, has a lot of side effects, and continues to have symptoms. The other patients that I see often are those who are looking for, a more natural, more long-term approach to care. And those are the other folks that I think are really excited about immunotherapy and the benefits it offers in needing less medication over the long term and having better symptom control. The other group of folks that I think have the best, long-term potential are our younger patients.
Mhm.
So when we look at some of the data for immunotherapy in kids and teens, there is data to suggest we see less potential progression of allergies into asthma, less formation of new allergies over the long term by kind of changing that milieu of what is going on in the immune system. So those are the other group of patients that I think really can benefit from long-term treatment options.
We're talking to Kara Wada. She's an adult and pediatric allergy, immunology, and lifestyle medicine physician. Today's Kevin MD article is titled Ragweed Allergy Peaks During the College Football Season. Kara, tell us some of your take home messages that you want to leave with the Kevin MD audience.
Yeah, so I think first and foremost, you don't have to suffer through allergy season, using a combination of trigger avoidance, keeping your windows closed, medications, and or immunotherapy, we really can get significant improvement and relief of your symptoms. So I think that is the take home message. And if you are having ongoing symptoms, we're here to help.
Kara, thanks once again for coming back on the show, sharing your time and insight.
Thanks so much, Kevin. Take care.